Let's talk about how you'd manage this. If the fungal infection is on the head, we call it tinea capitis. Do we treat it orally or with a topical? We use oral treatment. Why? Because tinea capitis infects or affects the hair shaft, right below, so it's not a superficial infection. So oral for capitis. Tinea corporis, how do we treat that? It's on the body. Topical agent. Tinea cruris, which is jock itch. How do we treat that? Topical agent, because it's a superficial infection. Tinea pedis, how do we treat that? It's a superficial infection. We use a topical. Tinea unguium, what is that? It involves the fingernails. Oral always. Oral is so much more effective, and usually superficial is not effective at all. So the two oral agents will be capitis and unguium. Is everybody with me? All right. Take a look. Which clinical features are common to tinea corporis or corporis? Well, we often see central clearing, circle number 1. We can see a circular plaque, circle number 2. We could see an oval patch, circle number 3. We could see an annular ring, circle number 4. We would not see a moist circular plaque. We would not expect a patient to tell us that it hurt, but we would expect scales right around the edge of the lesion. So look at a good example of that. So it's in a circular pattern. It appears to me that there is central clearing. Do you see it? And do you see the scaliness? You see it? So, yeah, I think all of those make me think that that's a fungal infection. Topical agent, right? Topical agent. Look at this example. This is an example of tinea cruris, which always affects the inner thighs, but it never affects the penis. You know, the American Academy of Dermatology has a slide index that you can go in for free. You can take these pictures and use it. I think I'm going to send them an email because I got this from there. There are no gloves on that patient, and that hand doesn't match that body part. I'll let you know what their reply email says. All right, so when's the last time you had a fungal infection? Probably probably been a long time ago, or maybe not at all, not even in your recent memory. When patients get fungal infections, especially if they're bad or they're extensive, we start thinking about something else going on with them. So look at my question. Fungal infections are expected to be more common in patients who... Tell me about it. If they don't have a spleen, they're considered to be immunocompromised. Circle it. If they have hepatitis C, circle it. No. Don't get tricked on number 3. What does it say? Immunocompetent. It didn't say compromised. All right. And maybe the most common reason you're going to see fungal infections is number 4. They have poorly managed diabetes. So I would circle all of them except number 3. Y'all on it? All right, here's another image for you. There are 2 images up here. Here's the first one. And I don't know what in the world that is. It looks kind of fungal because it's central clearing. And then here's another picture, and oh, I know what this is. It's called pityriasis rosea. P-R is what your colleagues call it. Pityriasis, P-I-T-Y-R-I-A-S-I-S. Pityriasis rosea is the second word. R-O-S-E-A. Not rosacea, but rosea. So pityriasis rosea, we don't know why people have it. We think it may be viral, but there are 2 hallmark findings in a patient with pityriasis rosea. You'll see it in practice, and it often appears on the exam. This is called the Harrow patch. The Harrow patch, it appears on the trunk about a week before the appearance of that other rash. and it looks like a ringworm. It's called a Herald patch. The second thing, if you miss the Herald patch, when they come in about a week later, they're going to have a rash that looks like this. This is called the Christmas tree pattern rash. Now look, they make jokes about dermatologists. You know, they say to be a dermatologist, you got to have a really good, creative part of you. So let me see if you could be a dermatologist. See if you see this Christmas tree pattern rash. Here's the trunk of the Christmas tree. Oh yeah, Emily, I got that. Let me show you the branches. Look how they go down. You see it? Here comes the Christmas. You see how they are? So it goes down in that pattern. Look at them on this side. Do you see it? So it's called a Christmas tree pattern rash. And so I'll leave it at that. But Herald patch, Christmas tree pattern rash, you got to be thinking about pityriasis rosea. Does everybody have those words in their brain? All right, very good. Oh, so how do we treat pityriasis rosea? We let it run its course. If people itch, we could give them antihistamines. But honestly, pityriasis rosea is going to run its course. All right, everybody on it. Look at this image. What is this? Well, I'm looking at this circular kind of thing with central clearing. And hey, wait, in the middle of the central clearing, there's something right here. What is that? What do we call it? We call it erythema migrans. And when do we often see erythema migrans? In patients who have a history of a tick bite, which could cause a disease like Lyme disease, right? And so erythema migrans is kind of one of your red flags. Bullseye lesion is what may be described, and so there you go. Everybody got it? Take a look at my question. An antibiotic used first line to treat early Lyme disease and other tick-borne infections. What class of meds do we use? Doxycycline, exactly. Number 3. Let's talk about herpes zoster. And another name for herpes zoster is shingles. So here's what happened to everybody in this room when you were a little girl or boy. You got exposed to the chickenpox virus. Even if you tell me, Emily, I never had chickenpox, you got exposed to the chickenpox virus. And lying dormant right now inside of you is that herpes zoster virus, varicella zoster. And if something comes along and wakes up that virus in whatever dermatome it wakes up in, you're going to have shingles. So it's a reactivation of the varicella zoster virus. And man, is it painful. The most important thing to remember about shingles is that it affects a single dermatome, not multiple. If multiple dermatomes are affected, something else is going on with that patient. Maybe they're immunocompromised. Maybe they're a diabetic who's out of control, but something else is going on with those patients. Shingles affects a single dermatome. Now, we don't usually get to see the vesicles associated with shingles. They appear and they resolve pretty quickly, usually before the patient can get in to see you. But these little fluid-filled vesicles are loaded with viral particles. So we don't want susceptible people to come in contact with that. Now, who's a susceptible person and what would happen if you did? Maybe somebody who was immunocompromised, maybe somebody who'd never had chicken pox. What would happen to them if they came in contact with that? They could get what? Shingles? No, chicken pox. So how else could you get chicken pox? Let me ask you something. When a patient who's a healthcare provider, let's say it's an oncology nurse, has shingles, she's got to leave that unit right now. Somebody else can bring you her purse. She's not going back up there. Why would we make that oncology nurse totally leave the unit and not go back to the unit? I mean, certainly she's not going to be rubbing up on patients with that, because There are two ways that you can shed this virus. One is with direct contact, and the other is with, look, through respiratory shedding. So you have to be really, really careful with susceptible populations. And I mentioned on oncology people, maybe it's a nurse who works in the neonatal ICU. You know you're going home and somebody else can go get your purse. You're not going back up there, right? So vesicles, we rarely see them. What about the shingles rash? This is a dermatomal rash, and you can just almost follow the dermatome. Now, I have to tell you that I've seen a lot of shingles in my life, and this is a pretty large eruption. Usually people have an eruption that looks like this, or they might even have an eruption that looks like that. But you cannot believe how much pain that little eruption can produce. Something else you need to know about. One of the most common places for shingles to occur is head, neck, and the trunk. The reason it's significant on the trunk is because your trunk is loaded with nerve endings. Haven't you taken care of patients with chest tubes before? Do you know how painful it is when they roll over or move? It's because of all the little nerve endings in the trunk. So when a patient has shingles in one of the dermatomes on the trunk, it's extraordinarily painful, even though the eruption looks like a pitiful little rash, but very, very painful. So how do we manage them? Well, a couple of things to note. One is we want to get an oral antiviral agent in them as soon as we can, preferably within 72 hours. We give an oral antiviral after 72 hours if they're still having new lesions appearing. You got it? So we give an oral antiviral within the first 72 hours of symptoms, appearance of the rash or the vesicles, ideally within the first 72 hours. After 72 hours, the benefit from the oral antiviral begins to drop precipitously. But if they're still having appearance of new lesions, we go ahead and we start the oral antiviral. And we always give an oral antiviral to people who are immunocompromised. Now, you see that thing up there that says NSAIDs? Doesn't that seem ridiculous? I've been telling you how painful this rash is. NSAIDs are given for a shingles rash or outbreak, not so much for pain control. Because one of the problems that happens in patients who have shingles is they get inflammation of the nerve endings. So when you give an NSAID, I hope it helps your pain. But the real reason I'm giving you an NSAID is to try to help reduce inflammation at the nerve endings. Now, there's another part to it, and here it is. Older adults more commonly get shingles than younger adults. And sometimes we can't give an older adult NSAIDs. I don't know if you know this, but when ibuprofen first came to market, it was a prescription medication. Do you know how much was a prescription dose? 600 milligrams, 800 milligrams. There were 600 and 800 milligram tablets, and the pharmacist would dispense them. The FDA said, hey, ibuprofen is a really good drug. Let's make it available over the counter, but we're going to put it in a non-prescription dose, 200 milligram tablets. When you look at an over-the-counter dose of ibuprofen, it's 1 to 2 tablets. That amount of ibuprofen, 200 to 400 milligrams every 4 to 6 hours, is not for inflammation. That's an analgesic dose. So when you use an NSAID in an older adult or anybody with shingles and you're trying to address inflammation, you have to give that 600 to 800 milligram dose. And a lot of you older adults are not going to be able to tolerate it. When you give a lower dose of an oral anti-inflammatory agent, you are simply taking advantage of the analgesic properties of that anti-inflammatory. You're not getting the anti-inflammatory properties of it. You follow me? So you got to give a higher dose. The same thing is the story with naproxen. Aleve over the counter. How much is an Aleve tablet? 220 milligrams of naproxen sodium. When you write a prescription for naproxen, how much is it? 500 to 550. That's the anti-inflammatory activity. So just keep that in mind. NSAIDs might be used, but be careful with them, especially in an older adult. Here's your patient. A 76-year-old patient has vesicles and pain on his right forehead and eyebrow. His right eye is red, and he feels more comfortable with his lid closed. In addition to treating with an oral antiviral agent, how should this be managed? Well, it sounds to me like he's got shingles. It's affecting his eye? Oh, where's this patient going? Ophthalmology, exactly. Circle number 4 and don't hesitate to send them there. And when you call to make the referral, they usually say, we'll take them now. All right, that's how important that is. Because as you know, that can lead to loss of vision in the affected eye. So, we have this wonderful herpes zoster vaccine. Do you know who ACIP is? It's the immunization arm of CDC. And ACIP is the organization that gives us all the recommendations for immunizations. And they say, listen, if you're 50 and older, we got this wonderful new vaccine to give you. And it's called Shingrix. It's a recombinant DNA vaccine. And it's got a higher efficacy than the live immunization that's on the market, still on the market, called Zostavax. So when patients come in for shingles immunization, the recommended, or the primary one that we give is Shingrix, and Zostavax is still on the market, but just be advised that it's not the preferred, although patients could still request it and get it. The immunization is still contraindicated in pregnancy because you know we're not giving pregnant patients anything. The other thing I want you to know is that while Shingrix is completely dead, it's a completely dead immunization, we're not yet giving it to people who are immunocompromised. There's a big study that ACIP will probably release in about 18 months, and I've been following it. So it looks like it'll be appropriate for that population, but it is not now, all right? But Shingrix is a big deal when you talk about older adult immunizations.